is the provided history. It's not really a, visual test, but I put arrows on the finding and then we'll kind of go through them individually. So the lady is 54, kind of non-specific abdominal pain, 2 months. Fishing, they're looking for an explanation for her abdominal pain. And this is her initial presentation, first set of images. So I'm pointing to blind-ended structure in the right lower quadrant. And so what are some of the options? I guess we can start with that.
Meckel's.
Yep. Perfect. So right lower quadrant, Meckel's, or appendix. This is separate from the appendix. I'll show you the appendix, which is normal.
Can you have like a gist who?
Yeah, so we'll go through that. Awesome. So Meckel's was our first thought. This was quite bulky looking. You'll notice that there's some high density material within it. And so this looked like basically a Meckel's, potentially with Meckel's diverticulitis, and maybe an enterocolitis, and we'll talk about that shortly. Some additional findings in this patient. So this I'm just showing you that the appendix is normal, so it's nothing to do with the appendix. Any observations on these two axial images for the rest of the study?
Peritoneal spread.
Yeah, so there's peritoneal haziness, most evident anteriorly here. And then the liver wasn't called, but it's quite subtle, and I'll show you a follow-up scan. So you have these little hypoattenuating areas. And so this certainly, the peritoneal, observation raised some concern that this wasn't just a Meckel's diverticulitis or Meckel's diverticulum even. Okay, and this is a follow-up scan on the same patient. A few months later, so here we have ascites, we have these big nodes. The liver lesions have clearly increased in size.
Look at neuroendocrine, yeah.
Right. Yeah. And this is what the Meckel's diverticulum looks like, not inflamed. And so you can see here that there is this kind of annular mass-like abnormality within the diverticulum. So this was a case of Meckel's diverticulum, actually with adenocarcinoma. So quick word on Meckel's diverticulum. So as you know, remnant of the omphalomesenteric duct, because of failed involution, 10 to 12 weeks of embryogenesis, when the midgut is supposed to return into the abdominal cavity. So common complications, mainly in the pediatric population, so hemorrhage, intussusception, diverticulitis, enterocolitis, which can actually, when it's large enough, cause intestinal obstruction. And the interesting thing about this case is that the most common cancer, although rare to begin with, is carcinoid. And typically those are asymptomatic carcinoids, and they're found incidentally on pathology once the Meckel's is removed for other complications. But this case was a case of adenocarcinoma, which is exceedingly rare. And the difference on imaging really is that it looks like adenocarcinoma is elsewhere in the bowel, so they have an annular appearance. So this was a nice example, and a patient already presented with peritoneal spread and liver metastases at time of initial presentation.
The high density stuff, what was that?
Yeah, it's actually an enterocolitis. I wish I could scroll, you would see it better, but it's a little ball of stuff with calcification.
Oh, gotcha. So separate from the tumor.
So like multiple complications in this case, so like cancer, enterocolitis, diverticulitis, and of course the spread of tumor. Okay, and this just a quick reminder, if there's any residents, rule of twos. That it's not perfect, but it's kind of a good review of what, when we think of Meckel's diverticulum, what to think about.